So imagine waking up from a successful surgery.
Right.
You're resting in your hospital bed, the anesthesia is wearing off,
Yeah.
as doctors have just told you the procedure went perfectly. The problem is fixed.
Which is exactly what you want to hear.
Exactly. But what you don't know, and what you obviously can't feel, is that at a microscopic level, your body is actively sabotaging the very cure you just received.
It really is wild to think about.
It is, because within mere hours of the surgeon closing that incision, this biological glitch gets triggered, and your internal organs are slowly being glued together.
Yeah, it's the ultimate medical catch-22. I mean, we are dealing with a scenario where the human body's natural, ancient defense mechanism, that instinct to aggressively heal any wound, actively becomes the patient's biggest obstacle to long-term health.
And that biological paradox is exactly what we are focusing on today. We're taking a deep dive into the surprisingly murky world of pelvic healing.
It is a very complex world.
It really is. We've synthesized clinical guidelines from the National Institute for Health and Care Excellence, the American Society for Reproductive Medicine, the Royal College of Obstetricians and Gynecologists, and a ton of crucial data from patient advocacy networks.
Right, because we really needed a broad perspective for this.
Exactly. And the mission here is to answer a completely counterintuitive question. Can the scar tissue resulting from pelvic surgeries and treatments actually destroy the results those procedures were meant to achieve?
And, the answer fundamentally changes how we have to think about medical intervention, because to really understand this, we have to look closely at the environment inside the abdomen and the pelvis.
Right.
The organs in there, your intestines, your bladder, the uterus, the ovaries, they are not rigidly bolted in place. They are completely dynamic. They are constantly shifting as you breathe deeply or, twist your torso, and even as you digest a meal.
Right, and they could do that without causing you agonizing pain entirely because they are coated by something called the peritoneum. It's a membrane that acts like a biological nonstick pan.
Right.
It constantly secretes this tiny amount of fluid to keep the friction at absolute zero.
Yeah, that frictionless environment is just vital. But the thing is, the peritoneum is also incredibly delicate. So the moment it is injured, whether that injury comes from, say, the cold steel of a scalpel, a raging infection, or even severe inflammation from a condition like endometriosis, the body perceives a systemic crisis.
It panics.
Exactly. It immediately throws up this biological scaffolding to patch the breach. Special immune cells called macrophages flood the area. They act like biological first responders, and they release these chemical signals called cytokines.
And these cytokines are essentially flare guns, right?
Yeah.
Signaling for repair cells to rush to the site.
Precisely. They summon fibroblasts, and these fibroblasts immediately start weaving what is known as a fibrin gel matrix.
Okay.
They lay down these sticky structural threads to cover the raw, injured tissue. It is basically the internal microscopic equivalent of a scab.
Okay, let's unpack this. Because, a scab forming to stop bleeding sounds perfectly normal. You scrape your knee, it scabs over, the skin heals underneath, and the scab just falls off.
Right, that's the normal process.
But in the pelvis, the body seems to completely misread the assignment. It sounds like the body's trying to use a regular Band-Aid, but it panics, dumps a literal gallon of industrial superglue onto the organs, and permanently sticks things together that absolutely need to slide freely.
Yeah, that's actually a great analogy. And that panic, that overreaction, comes down to a catastrophic failure in a specific cellular cleanup process.
Oh, really?
Yeah. So in a normal, healthy healing cycle, once the underlying tissue is patched, your body deploys an enzyme system involving tissue plasminogen activator, or TPA.
TPAK.
You can think of TPA as a set of molecular scissors. Its entire job is to cut up and dissolve that sticky fibrin matrix once it's no longer needed. That breakdown process is called fibrinolysis.
Right, so it dissolves the superglue so the organs can be free again. But when we're talking about pelvic surgery, the sheer trauma of the procedure somehow turns those molecular scissors off.
Yeah, the surgical trauma severely suppresses the TPA enzyme system. So the macrophages and fibroblasts, they just keep pumping out the sticky fibrin, but the cleanup crew is never allowed into the area to dissolve it.
Wow.
The balance between depositing the glue and cleaning it up is completely shattered. So the fibrin matrix stays intact, it hardens. Over time, actual connective tissue starts to scar over it.
That sounds intense.
And it gets worse. Blood vessels literally sprout into the scar tissue to feed it, followed by actual nerve endings.
Wait, really? So it goes from being a temporary sticky patch to a living, bleeding, feeling band of flesh.
Yes. We call these adhesions.
And the timeline for this transformation is frankly terrifying.
Yeah.
I think you might assume growing a thick, vascularized band of internal tissue takes, months or maybe years.
Oh, no. The biological cascade is relentless. The initial sticky fibrin exudate is forming within 3 hours of the surgical incision?
Yeah.
Yes. And if the TPA cleanup system fails to activate, those mature, permanent adhesions are firmly established within the first 3 to 5 days after the procedure.
3 to 5 days. I mean, you haven't even had your post-op checkup yet, and your bowel is already being permanently fused to your abdominal wall.
Yeah, it's incredibly fast.
And the scale of this problem is just massive, right? Looking at the data gathered by the Surgical and Clinical Adhesions Research Group out of Scotland, they're often called the SCAR group. They followed a huge cohort of patients for 10 years.
It's a landmark study, yeah.
And what they found was that about 1/3 of all patients who underwent open abdominal or pelvic surgery ended up being readmitted to the hospital for an adhesion-related complication.
And they aren't just readmitted once. The average was 2 readmissions over the following decade.
That's brutal.
And the specific procedure matters greatly, too. Open ovarian surgery carries the absolute highest risk for catastrophic adhesion formation.
Because the ovaries are constantly active, constantly moving, and they're deeply embedded in that peritoneal lining.
Exactly.
And when those fibrous bands take hold, they completely restrict the mobility of the organs. I mean, that pulling and tethering triggers chronic, debilitating pelvic pain.
Yes, the pain is a major issue.
But even worse, if an adhesion wraps around the small intestine, it can create a physical kink in the hose, like a bowel obstruction. And that is a sudden, life-threatening medical emergency.
It is the single most common cause of postoperative small bowel obstruction.
But, okay, let me push back on this a bit.
Yeah.
If we're dealing with a physical band of tissue, essentially a rogue rope holding the intestines hostage, why is this such a complex problem? Like, logically, a surgeon should be able to just go back into the abdomen, locate the band of scar tissue, and snip it. You untie the knot, the pain goes away, the bowel unkinks. Problem solved, right?
This raises an important question, and it actually brings us to the cruelest paradox in modern surgery. Going back in to cut away the scar tissue is a procedure called adhesiolysis. But think about the cellular cascade we just outlined. How do you remove an adhesion?
Well, you have to cut it with a scalpel or, burn it with a cautery tool, which means you are creating a brand new injury on the peritoneum.
Exactly. The mechanical act of cutting the adhesion creates fresh trauma. The macrophages deploy again. The cytokines flare. The fibroblasts rush in and dump a whole new layer of fibrin.
Oh, no.
And because the patient's system already demonstrated a propensity to suppress those TPA cleanup enzymes, they are almost guaranteed to do it again.
Those are backfires.
Completely. By trying to cut away the adhesions, the surgeon very often triggers the formation of a much larger, much denser web of scar tissue.
So it is a totally self-perpetuating cycle. The attempted cure literally causes the disease to spread.
It really does.
There was a landmark clinical trial led by Swank and colleagues that really hammers this home. They took a group of patients suffering from severe chronic abdominal pain caused by adhesions.
Right, the laparoscopy trial.
Yeah, they designed a randomized controlled trial where half the patients received a laparoscopic adhesiolysis, meaning the surgeon went in and meticulously cut away the scar tissue, but the other half received a sham surgery.
And that sham surgery methodology is really crucial to understand here. For the control group, the surgeons made the keyhole incisions in the abdomen, inserted the cameras, looked around, but purposefully did not cut a single adhesion.
They just looked.
Right. They simply closed the incisions back up. It was effectively a surgical placebo.
And when they tracked those patients' pain levels over the long term, the results were just staggering. The patients who had the physical scar tissue surgically removed fared no better than the patients who had the placebo surgery.
Not at all.
The physical act of cutting the bands provided no lasting relief, entirely because the body immediately went to work reforming those exact same biological bonds, often trapping the nerves all over again.
It fundamentally alters the landscape for any future medical intervention. Imagine a patient who had an ovarian cyst removed in their 20s. Now, let's say in their 40s, they require a hysterectomy or a bowel resection. The surgeon opens the abdomen expecting to see the clean, easily identifiable organs pictured in a medical textbook. But instead, they are confronted with a frozen pelvis.
A frozen pelvis, so like a fused, indistinct mass of tissue where the bowel, the uterus, and the bladder are all glued together into just a single block,
Exactly.
which turns a routine surgery into an absolute minefield. I mean, the surgeon has to spend hours meticulously dissecting millimeter by millimeter through this dense vascular superglue just to locate the organ they actually need to treat.
Yeah, it drastically inflates operative times, which keeps the patient under anesthesia much longer. It leads to severe blood loss because remember, those mature adhesions have their own robust blood supply.
Right.
And most dangerously, it radically increases the risk of the surgeon accidentally nicking the bowel or slicing into the bladder, simply because the normal anatomical landmarks are completely buried under thick fibrosis.
That kind of surgical complication cascade is exactly why the financial toll of adhesions in the U.S. alone sits at over $2 billion annually.
It's a huge burden on the healthcare system.
But honestly, the financial cost pales in comparison to the human cost, particularly when we look at the fertility toll. The way this biological superglue sabotages reproduction is devastating.
It really is.
Because for natural conception to occur, an egg has to erupt from the ovary, be physically captured by the delicate finger-like fringes of the fallopian tube, and then travel down that tiny corridor into the uterus.
Right, and adhesions utterly disrupt that physical journey. A fibrous band can lash onto an ovary and physically drag it out of position, pinning it behind the uterus where the fallopian tube can never reach it.
Wow.
Or, even more commonly, the scar tissue wraps around the fallopian tube itself and squeezes it completely shut.
And when a fallopian tube gets squeezed shut by scar tissue, it leads to a condition called hydrosalpinx, right? Since the tube is lined with specialized cells that are constantly producing fluid to help the egg float along, when the exit is blocked, that fluid has nowhere to drain. So the fallopian tube swells up like a water balloon.
And it isn't just a matter of a physical blockade. The trapped fluid within that swollen tube becomes stagnant and highly inflammatory. It is essentially toxic to an early embryo.
That is awful.
It becomes a massive hurdle even for patients who decide to bypass the fallopian tubes entirely and attempt in vitro fertilization.
Because even if the IVF doctor perfectly implants a healthy embryo directly into the uterus, that toxic fluid from the blocked tube can leak backward into the uterine cavity,
Exactly.
creating this hostile environment that literally washes the embryo away and ruins the chance of implantation. So a seemingly minor surgery to remove a cyst a decade prior ends up permanently sabotaging the patient's ability to carry a child.
Which is exactly why the clinical guidelines place such a heavy emphasis on the environment inside the operating room. We've learned that it isn't just about what specific organ you are operating on, it is about how you handle the microscopic ecosystem of the peritoneum.
Right.
This is the realm of microsurgical principles.
Right, the nuances of the surgery itself. For example, during laparoscopic surgery, keyhole surgery, the standard practice is to pump carbon dioxide gas into the abdomen to inflate it like a tent.
Right, to create space.
This gives the surgeon room to maneuver their instruments. But normally, hospitals use completely dry, room temperature CO2 gas.
And that is a massive problem for the peritoneum. That dry gas acts like a harsh winter wind blowing across a delicate mucous membrane.
Oh, wow.
Yeah, it completely desiccates the tissue. It strips away that frictionless layer of moisture, causing microscopic cellular death across the entire abdominal cavity.
And what does the body do when it detects microscopic cellular death? It triggers the macrophage flare guns, dumps the fibrin, and forms widespread adhesions, even in areas the surgeon's tools never actually touched.
Exactly.
But simply by switching to carbon dioxide gas that has been filtered, heated to body temperature, and heavily humidified, surgeons can prevent that desiccation. Keeping the internal environment warm and wet mimics the body's natural state, dramatically reduces the trauma cascade.
It is a brilliant low-tech adjustment, and alongside that, microsurgical principles dictate minimizing the use of laparotomy sponges, which are basically microscopic sandpaper to the peritoneum.
Yeah, I hadn't thought about the sponges.
It also means exclusively using powder-free surgical gloves, because even the microscopic starch powder used to lubricate gloves triggers a severe foreign body inflammatory reaction. Every stray fiber from a surgical drape, every tiny drop of blood left unsuctioned, serves as a scaffolding point for a new adhesion.
So if the mechanical trauma of a steel blade or the friction of a sponge is what triggers this biological superglue, it seems logical that using a non-contact tool would bypass the problem entirely.
You would think so.
Right. If cutting causes scarring, what happens if we don't cut? Here's where it gets really interesting.
Okay.
Because there is a massive trend in women's health right now,
Yeah.
steering away from scalpels and moving toward energy-based devices.
Yeah, we are talking about the booming market for therapies aimed at genitourinary syndrome of menopause, or GSM, which is often marketed under the umbrella of vaginal rejuvenation.
Right.
These interventions utilize fractional CO2 lasers, erbium lasers, or localized radiofrequency devices.
Because for a patient experiencing severe vaginal dryness, burning, pain during sex, or mild incontinence, which is often due to the massive drop in estrogen during menopause or after surviving breast cancer, these treatments are aggressively marketed as a magic wand.
Yes, very aggressively marketed.
No scalpels, no stitches, no downtime. You just go into a clinic, they use a laser, and the tissue is miraculously restored. But let's look at how these devices are actually functioning on a cellular level. Because they aren't bypassing the injury response, they are actively weaponizing it.
They rely entirely on intentional, controlled thermal microinjuries.
Controlled burns, essentially.
Yes. When a fractional CO2 laser is fired into the vaginal canal, the energy is absorbed by the water molecules within the tissue. It vaporizes the water, creating tiny, microscopic columns of thermal damage, essentially burning thousands of microscopic holes into the vaginal wall.
Which instantly triggers our old friends, the macrophages and the fibroblasts.
Precisely. The thermal injury produces localized swelling and tricks the immune system into an emergency repair protocol.
Right.
But instead of forming a massive scar, the goal is to carefully stimulate those fibroblasts to produce fresh type 3 collagen and new elastin fibers, and to encourage new blood vessels to form in the mucosa. The clinical term for this is neocollagenesis.
Right, so they were trying to harness that exact same superglue cascade, but throttle it just enough so it thickens the tissue and restores natural lubrication without turning into a solid scar.
That's the theory, yes.
And to be clear, for many patients who absolutely cannot use topical estrogen, these treatments can offer short-term relief. But what's fascinating here is how incredibly thin the line is between therapeutic collagen stimulation and pathological runaway fibrosis.
It is a razor-thin line.
Because we already know the pelvic region is uniquely prone to overreacting to trauma.
And when that delicate thermal boundary is crossed, the clinical outcomes are catastrophic. The National Institute for Health and Care Excellence, NICE, compiled a deeply concerning interventional procedure overview on these exact transvaginal laser therapies.
Yeah, reading those was tough.
The case studies they documented are stark warnings about the realities of energy-based intervention.
Definitely. One case involved a 61-year-old woman who initially went to a clinic seeking relief for mild dyspareunia, which is mild pain during intercourse. She was prescribed 3 courses of this laser treatment.
Right.
But instead of restoring her tissue, her body violently overreacted to the repeated thermal burns. She developed extreme vaginal dryness, severe burning, and itching that was far worse than her original symptoms.
And when clinicians finally examined her, they discovered that the laser had triggered a fibrotic response so severe, her body had constructed a crescent-shaped band of dense scar tissue right across the middle of her vaginal canal.
Unbelievable.
The treatment had literally built a physical wall, creating a stricture and a partial obstruction where none had existed.
It's horrifying. And there was another case documented involving a 65-year-old breast cancer survivor. Because of her cancer, she couldn't take hormone replacement therapy, so she turned to the laser to treat severe dryness.
Which is common.
Right. After 3 thermal treatments, she attempted to resume intimacy a few weeks later, and the fragile, newly altered tissue simply tore. She suffered severe vaginal lacerations that required emergency surgical repair with stitches.
Which, as we know, compounded the trauma. She now had thermal burns from the laser and mechanical trauma from the sutures. The resulting cellular panic led to massive runaway fibrosis.
Just a perfect storm for adhesions.
Yes. Several months later, her vaginal canal had become completely foreshortened. It measured a mere 2.5 centimeters in total length.
2.5 centimeters. Her anatomy was fundamentally, permanently altered by a device designed to rejuvenate her.
It's tragic.
And patients don't just walk away from an injury like that. The physical and psychological toll is immense. They are forced into grueling, multidisciplinary rehabilitation programs just to try and reclaim basic anatomical function.
The rehabilitation protocols require intense dedication and pain tolerance. Patients are prescribed off-label intravaginal Valium.
Wait, like the anxiety medication?
Yes, literally inserting sedatives into the vaginal canal every night just to try to chemically paralyze the severe muscle spasms caused by the tethering scar tissue.
Ah.
They have to use specialized topical hormones, and they are forced into strict progressive vaginal dilator programs.
And the dilator program isn't just about stretching, right? It's a daily mechanical battle against the collagen crosslinks.
Yes.
The patient has to use increasingly larger medical dilators for months, deliberately putting tension on the scar tissue to slowly, painfully force the collagen fibers to break apart and remodel.
It is a harrowing process, which is exactly why the consensus across major medical societies, including the British Society of Sexual Medicine and the Royal College of Obstetricians and Gynecologists, is one of extreme caution.
Yeah, that makes sense.
Energy devices should never be the first line of defense for vaginal laxity or mild menopausal symptoms. Evidence-based conservative care like targeted pelvic floor physical therapy, vaginal moisturizers, and localized estrogen must always be prioritized.
So what does this all mean for you? If you are navigating this medical landscape, the overriding lesson is that you must be your own fiercest advocate.
Absolutely.
Whether you are facing a routine cyst removal, an excision for endometriosis, or a cesarean section, you cannot blindly assume that the surgical team is utilizing every available strategy to prevent adhesions. You have to ask them explicitly.
You need to be asking questions during the pre-op consultation. Ask, what specific precautions do you take to prevent adhesions?
Right.
Do they utilize humidified gas for laparoscopy? Do they strictly use powder-free gloves? And perhaps most importantly, do they routinely utilize physical adhesion barriers?
Right. We didn't even mention the barriers. The FDA has actually approved several bioresorbable membranes products like Ceprafilm or Intercede.
Those are crucial.
They act as temporary physical nonstick sheets. So before the surgeon closes your incision, they lay these sheer membranes directly over the traumatized organs.
Yeah.
The membrane physically blocks the organs from touching each other during that critical 3 to 5 day window when the fibrin superglue is at its stickiest. Once the danger zone has passed, the membrane simply dissolves and is absorbed by the body.
And if you are considering stepping into a clinic for an energy-based treatment like a vaginal laser or radiofrequency device, you have to understand the biological mechanism you are paying for.
You are paying to intentionally injure your tissue.
Exactly. If you have any history of abnormal scarring, keloids, or if you begin experiencing new tightness or burning after a session, you must halt the treatment and seek a second clinical evaluation immediately.
The human body's healing mechanism is truly a double-edged sword. It wants so desperately to fix the damage that it ends up imprisoning the very organs it's trying to protect.
If we connect this to the bigger picture, it really leaves us with a profound, lingering question about the future of medicine.
Yeah.
Our biology is incredibly ancient, hardwired to form these fibrous bands in response to any intrusion, whether that intrusion is a stone arrowhead, the steel of a scalpel, or the invisible heat of a laser.
Right.
Will the future of pelvic medicine actually lie in inventing sharper tools or more precise lasers? Or will the ultimate breakthrough require discovering a genetic or chemical pause button that can temporarily turn off our very human instinct to scar?
Imagine that. Being able to administer a drug that simply pauses the fibroblast for a week, allowing the body to heal perfectly, cleanly, without laying down a single drop of superglue.
It would change everything.
Until that day comes, we have to accept the reality that sometimes the cure triggers a brand new disease. The pelvic landscape is delicate, the biology is unforgiving, and the superglue is always waiting. Keep asking the hard questions of your doctors, understand the mechanics of the procedures you agree to, and never forget the power of being an informed patient.